Okay, we won't be here for the full 4 hours, don't worry. Where'd that go? There it goes. Okay. So we're going to do lectures 9 and 10 today. We're going to do 8 and 11 on Friday. Then next Monday we'll do the medical marijuana talk and then review, and then neuro's over next Wednesday. So it's going through fast. So we'll do 2 lectures and then we'll be done. The afternoon lecture is technically a free lecture, but you have that. Don't forget to finish that that stroke scale certification, the NIHSS thing. So you can do that while we're done with class. So today we're going to go through the specific cranial nerve disorders, and then the second lecture is all about headaches. So we're going to go through our cranial nerves. So cranial nerve 1, olfactory. Smell is cranial nerve 1 and some portions of the trigeminal nerve. For smell, what does the trigeminal nerve tell you about the smell? They give you like warmth, different types of qualities, where cranial nerve 1 is just identification. You put the chapstick or whatever below their nose, and they smell, yes, that's cinnamon, this is vanilla, but the trigeminal nerve will tell you, does it smell, is it warmth to it, the acidity to it, does it hurt your nose when you breathe it in? That's all trigeminal nerve. And so like overtones, the sharpness of the smell, any tingling or irritation, that's all cranial nerve 5 that does that. So we know from physio that all the receptors for the olfactory nerve, this is the part of the brain that actually is out of it's exposed to the air essentially. And that's how we can get all of our sensations. Ammonia smell is given by that trigeminal nerve. So everyone ever used smelling salts before? The trigeminal nerve is what kicks in and wakes you up. And again, here's all of our, how it works. Remember, it goes to the thalamus because it's sensory. So it's got to go there too. Part of it does. Some smell disorders, some definition words. Anosmia means they can't smell anything. Okay, hyperosmia, abnormally intense smell, and cacosmia, it's hallucination of fecal odor. Okay, a primary disorder of cranial nerve 1 are very rare. All of you have probably had a cranial nerve 1 disorder when you are sick, because they are secondary causes. All that phlegm and mucus that's in your sinuses and covers the olfactory bulbs, you're not going to be able to smell food. And because you can't smell it, that's why the food tastes bad, because smell and taste go together to give you the perception of what you're eating. And now your smell has been altered because of sinusitis, upper respiratory infection, head injuries, medications. Again, these are secondary causes for a cranial nerve 1 abnormality. The majority of the time, it's going to be secondary issues. So CT scan is very easy. Look at your sinuses. This is a frontal sinus scan. And obviously you can see all the buildup of mucus in the sinuses. Here's a little bubble there. Obviously you are filled up your sinuses with mucus from sinusitis, and that's why you're having smelling problems. Moving on to 2, 3, 4, and 6, our visual system. Cranial nerve 2 is the actual optic nerve, so remember that one. We cross over in that optic chiasm and go through the optic tract on either side. And then until we get to the back of the brain where our visual cortex is. And then we can put the pieces together and make an image. So here's all the fun stuff again. Remember from my class, I really focus on especially the optic chiasm with pituitary adenomas. Okay, just remember this whole combination for all your muscles. Lateral rectus is cranial nerve 6. Superior oblique is cranial nerve 4, and all the rest of them are 3. So it's easy to remember the cranial nerves and your EOMs for movement. Pupillary pathway. This goes through the oculomotor nerve, cranial nerve 3. Okay, is for your pupil response. So that gives you that direct consensual constriction when you put the lights in and all that fun stuff. That's all cranial nerve 3. So we talked about cranial nerve 3 in the past, mainly with diabetics. We're going to talk about it a little bit more today with regards to pupils. Historical things you don't want to miss with regards to someone coming in complaining of vision problems. Sudden onset of blindness, it's a vascular problem. Okay, we talked about different things with vision. And if they have strokes in that carotid territory, where deep down, before we get to the part of the brain, you're going to have vision loss on that same side. Slow evolution of visual complaints, so it's a slow progression, inflammatory or neoplastic diseases. They take a little bit longer to start having a consequence, you start seeing them. Transient or recurrent symptoms, think ischemia, embolic events, your multiple sclerosis is also here. They also get vision problems, so don't forget about MS, diplopia, the double vision, myasthenia gravis, and obviously the diplopia by itself can't maintain conjugate gaze because they're seeing double. They don't know which one to look at. Your complete visual system exam, obviously you're going to check everything. If they have any type of vision problems, do a fundoscopic exam, really looking for papilledema, any hemorrhages going on, anything to show any increased intracranial pressure. Obviously check all your margins, make sure that optic disc is okay. I know none of you guys can see it all, but when you actually get into the field, you'll have better equipment. It'll be really dim in the room, and hopefully ophthalmology will be on staff as well. So cranial nerve 2, monocular vision problems. So there's one eye is giving a problem. This is your transient monocular vision loss, unilateral loss of vision. So one side, your one eye is out. Your amaurosis fugax, optic neuritis, and giant cell arteritis are other causes that can give you a monocular blindness in one eye. So amaurosis fugax, brief fleeting attack, so it's transient, lasts seconds to minutes, usually due to decreased blood flow to the retina. So again, blood flow has to come up from the carotid, and when you have a blockage in the carotid, that main territory, everything above that is going to suffer. And if your retina doesn't have blood, all that imaging that goes onto it is not going to be effective. It's not going to give you any type of image. This gray-black curtain that gradually descends, blurring, fogging, or dimming of vision. Sometimes they'll experience vision loss that way, like the curtain's coming down, and then they can't see anymore. Other common causes of transient monocular vision loss, ischemia, whether it's cardiac in nature or cerebral vascular in nature, they're still getting lack of blood to the brain. And check all your vasculature, make sure the heart's okay, your carotids are okay, and so on and so forth. Make sure you work them up for a possible stroke too. If they already have blockages in the carotid that's preventing blood flow to the top, they have bruits, they may have some high velocities through their carotid artery Doppler. Make sure they don't have a stroke. What do you want to put them on? They're not on it already. What's the biggest one you got to put them on right off the bat? Aspirin. Just give them aspirin. Okay, they have a clot. It's an arterial clot. Aspirin, Plavix, those type of drugs are very good for arterial problems. Optic neuritis, inflammation of the optic nerve. You'll see it a lot with multiple sclerosis patients, so optic neuritis may resolve, most cases resolve spontaneously. They may have scotomata, which is the floaters floating around, visual field testing. Optic disc is going to be swollen, pupils will be slow to react. And you can give them steroids, anti-inflammatory, reduce the inflammation of the optic nerve. Okay, it's optic neuritis. So if it's inflammatory, you got to give them anti-inflammatory stuff. Here's your giant cell arteritis, inflammation of the external carotid artery at the superficial temporal artery, and that obviously can lead to blindness. So anyone coming in with, temporal pain, bulging artery on the side here, biopsy that, get a sed rate, your ESR, see what's going on with inflammation for that patient. So they're going to have pain over the temporal artery. They may have some jaw pain. Optic disc may appear pale. Again, they're not getting enough blood supply to the optic disc. You're going to have vision problems. And obviously, you need your biopsy of the temporal artery, your sed rates. Treatment, prednisone. Again, steroids, steroids, steroids. For anything with anti-inflammatory, steroids. Getting that in your mind and keep it there. Here's your optic neuropathy from temporal arteritis. Very pale disc there. And then look in this one, all the hemorrhages and how wide those vessels are due to the pressure they're having. Marcus gun pupils. This is an afferent pupillary defect. So is the problem going into the brain or coming out of the brain? Into the brain, okay? So due to a problem with our sensory system, the pupil dilates instead of constricting when pen light shines on it. So you have the opposite effect of what you would expect to see when you put a light in someone's eye. The consensual reflex is present in both eyes, and they may have some obviously disease of the retina or the optic nerve with these patients with a Marcus gun pupil. So defective sensory, so we're getting bright light. That sensation goes to the brain, but what's happening, the sensation going to the brain is not right. It's tricking your brain into thinking that you have less light coming in. So when you have less light, the eye is going to dilate. It's a sensory problem, not a motor problem leaving the brain going to the pupils. It's a sensory problem. So always remember that Marcus gun is sensory. Binocular vision problems. Now both eyes have an issue, not just one. So these things we'll talk about are affecting both eyes. Papilledema, pituitary tumors, and occipital tumors. So papilledema, increased intracranial pressure. Check for hypertensive emergency. We talked about that. So blood pressures can spike really high. Pheochromocytomas are the big ones. But when that pressure goes up really, really high, it gets transmitted into all the little small vessels of the eye and can cause papilledema from that. Intracranial mass. If you have any pressure in the brain, the skull is going to keep it stuck and it's going to start compressing structures. Impaired CSF flow and idiopathic intracranial hypertension. This is also called a pseudo tumor. So it's a fake tumor. They don't really have a tumor, but they have this increased intracranial pressure. They don't know why. That's why it's idiopathic. Treatment for that, you just put a shunt in and you drain off the excess CSF and it reduces the pressure. Other symptoms they're going to have. Headache. Obviously, you have all this intracranial pressure compressing against the skull. That's where the pain structures are located, and you get headache pain for that. Nausea and vomiting, and maybe some other neural findings as well, especially if they have an intracranial mass, whatever structures are being compressed. That's where you'll have your deficiencies as well. And here's more pictures of your papilledema as well. Here's your splinter hemorrhages and whatnot from all that pressure. Pituitary tumor, it's going to affect your optic chiasm, causes bitemporal hemianopsia. Again, prolactinoma, pituitary is the most common. Headache, they're going to have these symptoms are due to issues with the pituitary gland itself, not the vision. So remember we learned about the pituitary tumor, whatever tissues in the pituitary gland have the tumor, they're going to push out a lot more of those hormones. So if it's in the growth hormone in your somatotrophs, you're going to have acromegaly because you have too much growth hormone being spit out. But they're going to also complain of vision problems as well. So you got to put it all together. Best evaluate with MRI. See the tumor right there. And then obviously MRI will be later on, but get your prolactin levels, check your endocrine levels to see if any of those are out of whack, which means you have a pituitary tumor possibly. Treatment for pituitary tumors, you just get rid of it. Surgical excision, same thing way they did with the Egyptians back in the day. Up the nose, and you can get it out through intranasally to go out that way. The other thing we give is bromocriptine. Bromocriptine is a dopamine agonist, used in the treatment of pituitary tumors and Parkinson's disease as well. So you'll see this drug come up when we get to Parkinson's, bromocriptine. Occipital cortex lesions. Again, this is where vision occurs, and we process our vision in the posterior side, occipital lobe. If you have any lesions in there, any issues, they may get some bilateral vision problems. And again, those things all make sense. If they damage the occipital lobe, you're going to have problems with vision. Cranial nerve 3 palsy. Okay, so with a cranial nerve 3 palsy, this is your oculomotor nerve, they're going to have diplopia, ptosis, fixed position of the eye downward and outward. You're also going to see dilation of the pupil. So these are the things that you'll see with a oculomotor cranial nerve 3 palsy. So anyone that comes in with a cranial nerve 3 palsy, and you can see on this vision right there, that is the cranial nerve 3 palsy right there. Okay, fixed position of the eye downward and outward. Pupils are dilated compared to the normal one. Okay, so that's a cranial nerve 3 palsy. Now, anyone coming in with this type of presentation, the one eye is fixed downward and outward and dilation of that pupil, you have to do a couple of things first. Rule out cerebral artery aneurysm. So you obviously get a CT, make sure they don't have any bleeding in the brain. Trauma, just ask, were you involved in trauma if they can respond to you? Car accident, whatever. Meningeal inflammation. What would they complain of if they have meningeal irritation? Neck stiffness. What are the other 3 things? The 3 things for meningitis. The nuchal rigidity, fevers, and headache is one of them. What physical exam test would you do? There's 2 of them. Just the names, just to describe it. The 2 Koenig's and Brzezinski's. Okay, those are the tests you can do for meningitis. Tumor, you'll see on CT, and ophthalmoplegic migraine, obviously going to have a lot more other symptoms along with those. So any patient with a new onset cranial nerve 3 palsy, got to rule out that cerebral artery aneurysm first before anything. Make sure that's okay. Because if they're having that aneurysm, that can be treated with early detection. The longer you wait, the worse it's going to get. They're also may have some associated ptosis, extraocular palsies, but you can see here that eye is downward fixed. You can kind of see a little bit of the pupil right there compared to this one. But dilated pupil, fixed outward gaze. Ptosis, obviously in this next picture, he can't keep his eyelid open. Ptosis, remember it's lid lag, inability to get the muscle up. This is all due to a cranial nerve 3 palsy. Now, if they have a downward outward gaze of a fixed eye, but the pupil is spared, diabetes. Always diabetes. So if the pupil is the same as the normal one, it's diabetes. If the pupil is enlarged, you have to rule out all the things we talked about before. Often resolved within 3 months. Guess how it resolves within 3 months? What do you got to do for that patient? Glucose control. That's always number 1 with any diabetic. Got to control the glucose. Because we eat all the glucose. We don't get it from anywhere else. So watch the diet. You have a question?
So what if someone has optic neuritis and the treatment is steroids, but they're diabetic? How would you
increase their diabetic medications while they're on the steroids? Good question. But again, you got to rule out the aneurysm first. Even though the pupil may be spared, always rule out the aneurysm first. Any type of cranial nerve 3 palsy. And just remember, if the pupil is dilated, it's a true cranial nerve 3 palsy. If the pupil is spared, it's due to diabetes. Anisocoria, which is unequal pupil sizes. You can see very easily in this picture. Here's a big one, there's a small one. So you have pupils that are unequal in size. Got to figure out which one's the normal eye and which one is the bad one. How do you know in this one? You don't. So we have to go through a couple of algorithms to figure that out. So identification of the abnormal pupil with anisocoria. So let's go over A. A is a normal reaction. So both eyes are in the dark. They should be dilated, right? We're in the dark. Absence of light, both pupils should dilate. We shine the light on the left one. It dilates. Oh, sorry, the right one, and the left eye dilates, constricts as well. That's your consensual response. That's normal. Light source on the left, they both constrict. And then finally, you have your near target one, and again, pupils constrict. This is your normal response when you do your directed consensual light responses. Let's go to B now. B, the small pupil is abnormal. So here is B. So the small pupil, I said, is abnormal. The small one is the right eye. So in the dark, the right eye is still constricted, but the left eye, which is the normal eye, is dilated now, which is the way it should be in the dark. But now we put the light source. Light's in the right, we get consensual response on the left. Left side light source, the pupil is still fixed and constricted though, so it doesn't really change that much. So in this case, the dark light tells you which pupil the problem is. You put them in a dark room, both pupils should dilate, but the right eye stays constricted. That is the abnormal eye because it doesn't respond like it should when you do your normal exam. C, in this case, the large pupil is abnormal. So in C, they're in a dark room. Both eyes are dilated. That is your normal response to the dark. You put the light source on the right eye, which is the bigger pupil. It doesn't constrict. Everyone see that? That pupil doesn't constrict in light, which means that is the pupil, that eye is having your problem. Because in normal response to light, it should constrict, and it doesn't. And then you confirm it by putting the light source on the normal eye. You should see consensual response in that pupil, but you don't anymore because it's got a damaged pupil. So that is anisocoria again. How to figure out which one is, and this one is a physiologic anisocoria. The amount is the same in light and dark, so there is a little bit of a change at least. You can see here, between those two pupils, when you do put it in the light, it does constrict some. And there is consensual constriction of these eyes as well. But again, you just have physiologic anisocoria, maybe due to surgery they had in the past, or they had cataract surgery or vitrectomy, some sort of eye surgery. They may have a damaged pupil just because of the procedure. So in your history, if they mention, oh yeah, I had eye surgery, then you would say anisocoria secondary to eye surgery on the right eye in whatever year. And you go from there. So that's looking at how do you identify which is the abnormal pupil if they have different sized pupils. Okay, Horner syndrome. This is interruption of the cervical sympathetic nerves. So we're only dealing with sympathetic nerves. That leads to ptosis, meiosis, and anhidrosis on the involved side of the face. So in this picture, we have the right and we have our left side. Left side, he's sweating, dilated pupil, and the eye is okay. Let's look at the right side, the affected side, the involved side. No sweating. Okay, could we blocked out the sympathetic system? The sympathetic system is for sweating. It's gone, you're not going to sweat. Ptosis, get lid lag. Okay, the lid is not really open all the way, it's kind of halfway down. And meiosis, which is just the constriction of the vessel, of the pupil. So that's what Horner syndrome is. Remember, Ptosis, meiosis, and anhidrosis on the affected side. And that's Horner syndrome. So it's a unilateral syndrome, unilateral meiosis. Either the affected abnormal pupil does not dilate in the dark or delayed dilation response, called dilation lag. The anisocoria in the dark is greater after 5 seconds, so it takes a little bit to kick in. And they may have some other isolated lid ptosis as well, or delayed eye elevation. So that's what Horner syndrome is. So the way you can confirm Horner syndrome is you do the cocaine drop test. It's topical cocaine. You put 2 to 4% solution into the eyes. What cocaine does, it blocks the reuptake of norepinephrine at our sympathetic nerve synapses, causing pupillary dilation in eyes with intact sympathetic innervation. So long as the sympathetic system is working, when you put the cocaine drops in the eyes, you should have profound pupillary dilation. If they don't dilate and they stay constricted, you have Horner syndrome because you have blocked the nerve and it's not working as well. No effect in eyes with impaired sympathetic innervation, regardless of the lesion location. So if there's issues with the sympathetic system, you're not going to have the dilatory response. And 1 hour after giving the cocaine solution, the normal pupil dilates more than the Horner's pupil, making that degree of anisocoria even worse. So this is a way to figure out, again, what side are they having the issues on, because they may come and see you. They're not going to be actively in type of sweating on one side versus the other. You may not see everything, so you can do this as well. And 0.8 millimeters or more difference between the two eyes is confirmation of the test. So evaluation of Horner syndrome, you get your imaging done, make sure it's neck and chest, so you get everything done. Neuroimaging, MRI of the head, angiography if you suspect carotid artery dissection, and think lung tumor or carotid artery aneurysm are the big culprits as far as why someone would develop Horner syndrome. So that's why you need head, neck, and chest, because the chests are involved because of possible lung tumor, the neck, possible carotid artery aneurysm, dissection there in the brain, look at all the vasculature in the brain as well. So the pearl. If there is ptosis on the eyelid that has the small pupil, they have Horner syndrome on that side. Okay, so if the ptosis of the eyelid is on the side of the small pupil, it's Horner syndrome. If there is ptosis of the eyelid on the side of the large pupil, then it's a cranial nerve 3 palsy on that side of the lesion. So you're trying to differentiate between Horner syndrome and cranial nerve 3 palsy. That's why we put them together, because they present similar. Okay. Argyll-Robertson pupil, you're consistent with syphilis, other type of conditions. Pupil will accommodate to near vision, but they won't react to light. So you put light in them, nothing really happens. You have them accommodate for near vision, and their pupils will constrict for that point, but when you put light in it, they don't. So that's an Argyll-Robertson pupil, again, associated with syphilis. An Adie's pupil is a tonic pupil, parasympathetic denervation. So now the parasympathetic side of things is altered. So they're going to constrict poorly, because the parasympathetic is the constriction part, but reacts better to accommodation. So you can see in the dark, both pupils are about the same size. Then we go to room light, and this one constricts, but that one still doesn't. Now we go to bright light. Constriction, dilation of that eye. Now we go to near. Pupil changed a little bit, right? The size of that pupil got better with near accommodation. which is again what you're going to see with knee accommodation. The pupil will respond, but everything else it doesn't. And this is a good flow sheet to when you're reviewing, looking at people with anisocoria. Go through your medical history first, an examination, then you start going through this algorithm to figure out what issue you're having. So at the bottom here here's your Horner syndrome, physiologic anisocoria, your 80s tonic pupil, third nerve palsy, and another one of pharmacologic. Here's your pharmacologic anisocoria. Certain drugs can also cause it as well. So those are the ones we went through, kind of work backwards and figure, okay, fine, let's figure out the puzzle here. If I have this presentation with these type of pupillary responses, work your way down, and you figure out your answer from there. Okay, so here's one for you. Doesn't look very well, but figure it out. Okay, cranial nerve 4 palsies. We're going to have diplopia, most common cause of vertical diplopia. Okay, so the vision is going up and down, not side to side. So say they're seeing double, do you see the double heads? Are they on top of each other or are they side by side? If they're side by side, that's your normal diplopia, but if it's up and down, think cranial nerve 4 palsy. Blunt head trauma is the most common cause of this. Other causes, diabetes is here, and your neoplasms and so forth. That's what a cranial nerve 4 palsy is. So in this one, you kind of look at where they're having the issues. So what does cranial nerve 4 do? So A, the involved right eye is elevated on a forward gaze. So this is the right eye, and here's your left. You see how the right has space underneath compared to the left eye? That is that upward forward gaze that's a little higher than the other side. It's elevated. Now we go to B. The elevation is increased with adduction. So in B, see the eye is up in that quadrant, not looking straight ahead. So the upward gaze is even worse when you have adduction. C, the elevation is decreased with abduction. So you can see the pupil is in line now with the side that it's looking at. But again, the right eye is still affected. It's just that with abduction, the height of the pupil goes back into normal vision again, normal line with that one. D, head tilting makes to the affected side will make it worse. So we're tilting our head. Here's the right. There's the left side. We tilt our head. Again, look at the pupillary levels. You're going to see this distance got greater when you tilt your head to the affected side. So if I have a lesion on the right and I tilt my head to the right, that cranial nerve 4 palsy will make the eye go up higher in the spectrum. Yeah?
Why is that?
What muscle are we talking about? That's why. Think of the muscle, the EOMs. So what is it, SO4? Superior oblique. So that's out. That's why you have issues. And the last one is when you tilt to the opposite side, it gets better. More in line. So if you tilt your head to the affected side, the gaze gets worse. When it's on the unaffected side, the gaze gets better. So that is looking at cranial nerve 4 palsies. Causes, trauma, microvascular disease, neoplasm, the most common. If they have a bilateral cranial nerve 6 palsy, is a sign of increased intracranial pressure. Occurs usually in conjunction with other, I'm sorry, this is 6 the whole time. Cranial nerve 6 palsy, if it's bilateral, both sides, increased intracranial pressure, and you'll have this in combination with other ones as well. So this is a cranial nerve 6 palsy. The affected eye, the right eye, is adducted at rest. Okay, his left eye is looking kind of almost forward, but it still is going to be adducted. And the affected eye in B cannot abduct. So we're looking this way, but the eye only gets to that point. The eye doesn't bottom out into the corner of the sclera. Okay, so that's cranial nerve 6 palsy. With a cranial nerve 6 palsy in elderly patients, think microvascular infarction. Again, due to diabetes, it can be cause of this problem. Tumor is more common in children and young adults. But anyone with a bilateral 6th cranial nerve palsy, increase intracranial pressure until proven otherwise. Get your scans done, see what's going on, check for your papilledema, signs of increased intracranial pressure first with any cranial nerve 6 palsy. Cranial nerve 5 problems. Now we're moving away from the eyes. Trigeminal neuralgia, also known as tic douloureux. It's another way of calling trigeminal neuralgia. Microvascular compression of the sensory fibers of your trigeminal root by a blood vessel, usually the superior cerebellar artery. They get lancinating pain over one of those branches of the trigeminal nerve. It is very painful. Even like taking a Kleenex and like rubbing against their face will cause immense pain in their face just from brushing it. They won't brush their teeth, they won't shave. If it's up here, combing their hair can hurt because of the pain from this trigeminal neuralgia. So very painful, sharp electric-like spasms, last a few minutes to seconds. Pain is usually only on one side of the face. And again, with your trigeminal distribution. There are 3 branches, so remember what they are because they're all some of them may be affected, some of them won't be. Pain may be triggered by just touch, draft of air or sounds can make that pain even worse. Pain occurs, again, brushing teeth, chewing, drinking, eating, shaving makes the pain worse, so they avoid those things. Get your physical exam, CT, MRI, usually all going to be normal, usually a spontaneous recovery. But again, this is nerve pain. It's trigeminal neuralgia, which means it's nerve pain. So you have to give medicine that helps with nerve pain. That's why gabapentin is here, carbamazepine. Baclofen is mainly for spasms, but again, they may help with this as well. But again, this is nerve pain. That's why NSAIDs, your opiates aren't prescribed here because it's nerve pain. It's not muscle pain per se. Cranial nerve 7, idiopathic facial nerve palsy, also known as Bell's palsy. And it's a reactivation of the HSV herpes simplex virus infection. Usually going to have facial paresis, so one half of the face is down, not going to work. Accompanying symptoms, oral pain, numbness in the side of the face that's being affected. Auditory hyperacusis, so really hearing weird sounds. Impaired taste on the anterior 2/3 of the tongue. Why is that? Remember, the facial nerve gives you the anterior 2/3 of your taste buds travels the facial nerve. Posterior 1/3? What? Glossopharyngeal. I think it's that one. Or hypoglossal. I think it's glossopharyngeal. One of those. I won't test you on it because it's not part of this class, but I'm not worried about taste. Symptoms do develop over a few days. They may have some oral pain, AU oral, not oral from the mouth, but oral in the hearing. In half of the patients will have a prodrome, oh, my ear was hurting for a little bit, and then it ruptures and they have Bell's palsy, facial nerve paralysis. Complete recovery in about 80% of the patients. Okay, prednisone, burst and taper. You got to get that swelling down, so you give them a bolus of, like a Medrol dose pack. You bolus them at first really, really high, then after every day you decrease the dose by 1 or whatever it is over the time. Acyclovir. Why are you giving acyclovir? Because it's herpes simplex is what's causing the problem. So acyclovir is for viral. So you give that one as well. People with complete paralysis that don't improve in a couple weeks should go to an ENT. for evaluation of other cranial nerve problems. So if they don't do better in a couple weeks, send them to ENT for evaluation. Recurrence, chronic symptoms at about 10% of patients. So if they have Bell's palsy once, 10% of them will have a recurrence of it at some point. So here's the mountain from Game of Thrones. He has Bell's palsy, and you can see his face. Only half of the face works. Look at that as well. The forehead. We're going to talk about that in a minute. So the side that's down, well, we don't really see much in this one, but I'll show you in a second. The forehead muscles is a clue when it comes to Bell's palsy. What also may present like that? Let me learn. Strokes. So how do you know the patient's not having a stroke versus having Bell's palsy? The key are the forehead muscles. Okay? When the forehead muscles are spared, they raise their eyes. You guys do this, right? Raise your eyebrows. Look at the forehead. Not Brittany anymore, but some people. Look at the forehead, you'll see wrinkles. Okay? If you don't see wrinkles, it's Bell's palsy, because the forehead muscles are innervated from both sides of the brain. So if they have a stroke, the forehead muscles are spared. They can still get wrinkles on both sides. That's the key. So when forehead muscles are spared, it suggests a central lesion. So they have a stroke because the forehead muscles are spared, because the forehead gets input from both sides. Okay, so like here, patient can elevate both eyebrows. You still have eyebrow or the forehead wrinkling. That is a stroke. This case, only half. Bell's palsy, because the facial nerve is now paralyzed essentially, so you don't get that rise of the eyebrows. Okay? And also with a stroke, they can close both eyes, but on Bell's palsy, the right eye does not close and the eyeball turns up. So that is Bell's palsy on the right as well. So that's how you can tell Bell's palsy versus a stroke. They both may present with facial droop, unilateral facial numbness and droop. Obviously, the thing that's going to kill them the fastest is a stroke, so you want to rule out stroke first. Once that's been ruled out, then you go on, okay, this could be just Bell's palsy. Ramsay-Hunt syndrome is an HSV eruption or re-eruption along your cranial nerve 7. They get facial nerve weakness just like in Bell's palsy, but the thing is they get a vesicular rash as well. So this is a form of shingles along that dermatome pattern. They're going to have prodrome of pain, otoscope exam. Obviously, vesicles are going to be in the ear. They're going to have problems with hearing on that side because obviously all that swelling that's going on in that area. These people refer to ENT immediately. Okay, make sure they get involved. Make sure that all the nerves are okay. MRI may show some inflammation of cranial nerve 7. Nerve conduction velocity, because the nerve is now damaged. It won't transmit that signal so fast anymore. So that's going to be slowed. And again, because it is a herpes simplex antiviral and help with the swelling, you also give your steroids, prednisone again, same one all the time, and adequate pain control. So they're going to be immense pain with this. What type of pain meds do you want to give them for this one? Nerve pain, so gabapentin, Neurontin, those type of medicines to block the nerve pain that they're going to be receiving or getting painful. Cranial nerve 8, we did already. Go back to last lecture on disorders of equilibrium. We already did this all. This is all a repeat. We can skip over that. The cochlear portion, though, we only did the vestibular as far as the balance issue. Let's talk about the hearing side now. Conductive hearing loss is external auditory canal or the middle ear. So again, look at your Weber and Rene tests. Weber will lateralize to the side of the lesion with conductive hearing loss. And the Rene bone conduction is greater than air on the side of the lesion. So this is an air conduction problem. It's not, the signal's not getting into the inner ear where we can transform it to a electrical signal so we can hear things. With sensory neural hearing loss, this is the inner ear or cranial nerve 8 by itself. And the Weber will lateralize away from the lesion with sensory neural. And the Rene test, air conduction will be greater than bone conduction. Both will be decreased on the side of the lesion. So both air conduction and bone conduction on the side of the lesion, both of them will be reduced. But air conduction will be greater than bone because you have a sensory problem now, so nothing is going to convert that signal. Therefore, you can't hear anything. Cranial nerve 9, 10, and 12 palsies. Cranial nerve 9, diminished gag reflex or disturbed swallowing. So you all defer that on your physical exam, but that's what you're looking for with the gag reflex, cranial nerve 9. Cranial nerve 10, we're looking at asymmetric rise of the uvula. Okay, open your mouth, say ah, and you're looking at the uvula to see, make sure it's staying midline. Is it going to one side or the other? The last one, cranial nerve 12, flaccid paralysis of the tongue with atrophy, some speech difficulties. What do you guys do to figure out cranial nerve 12? What do you have the patient do? Stick your tongue out, go side to side. Okay, so why is that important? Let's talk about cranial nerve 9 and 10 dysfunction. This is obviously stroke patients. So I always mention with stroke patients, don't let them eat or drink anything until they pass a swallow study. And these are the nerves that are all involved with swallowing deglutition, so you have to test them to see how they're doing. With a cranial nerve 9 and 10 dysfunction, the uvula is pulled over towards the right, the normal or strong side, because this side of the palate is pulled up higher. So the uvula will shift to the normal side. So in this case, uvula is shifted to the right. Which side is affected? The left side is affected because the palate is not rising with phonation because the nerve is damaged. Only the right side is raising. Therefore, the uvula is going to get pulled to the strong side towards the normal side because that's the only side that's rising up. So that's what the uvula. When we get to the tongue is the opposite. In this case, the patient has a right cranial nerve 12 dysfunction. The tongue will deviate toward the right to the weak side. So with the tongue, it always goes to the weak side. The uvula bends to the stronger, the normal side. Okay, cranial nerve 12 innervates the tongue muscles, genioglossus, hypo, and so forth. The deviation of the tongue towards the paralyzed side because of the weakened genioglossus muscle. The muscle isn't there to keep the tongue straight because it's down because of the stroke, so the stronger side pulls it. No, it gets pulled towards the paralyzed side, not keeping it straight, so it gets turned over to the side. So this is a right side dysfunction. Tongue is going to deviate to the right, to the affected side. Cranial nerve 11 palsy, this is your spinal accessory nerve. Just look for a winging scapula. Okay, scapula winging when you do your movements. Okay, that's a cranial nerve 11. What do you guys normally check for that? How do you do that one? Shrug your shoulders, side to side movements, those things. You can also look for the scapula to see if it's not coming up all the way when you raise your arms up, because that's a problem with the spinal accessory nerve. Altered taste of smells and altered sense of taste. Cranial nerve 5 is involved. Your 7, 9, and 10. Bell's palsy, they're going to lose taste of the anterior 2/3 of the tongue. So keep that in mind as well, because again, that's the facial nerve. Bell's palsy is facial nerve paralysis on one side, so they're going to lose the sensation of taste on that one side as well. Medications, ACE inhibitors can cause taste issues as well. Okay. And we are done for this lecture. Come back at 1:30.